the first one is Ms. Ashana Siwa, MBBS, DT, MPH, Master of Science in International Health. Apologies, Miss, if I mispronounce your name wrong. And we also have for the second speaker, Dr. Irwan Saputra, SCAP MKM, sorry. And the third speaker is Dr. Martinez, Master of Science, MPH, from Shahpala University. Yeah, so both our male speakers are from Shahpala University. And the last one, the last but not least, is Miss Maya Imarquez, the candidate of PhD at, and also the lecturer at University of Göttingen, Germany. So, hello everyone. Thank you for being here today. I hope you are here already. Hello, my name is Septia, and we already have a great audience today, which is very eager to listen to your talks. All right, without any further ado, maybe let me just give the screen to our very first speaker, Ms. Ashana Siwa. But before that, let me read about her a little bit. So, Ms. Ashana finished her bachelor education in Medical College, Pune, India. And then she gained her master degree in Charité University of Medicine, Berlin, Germany. And she is a global health professional with several years of combined work experience in the field of international and global public health and clinical medicine, spanning across the government, private academic, and non-for-profit sectors. She has a very extensive work experience, but as you know, and it's already shown on the brochure that she works with WHO HK in Geneva as case management expert, consultant from November 2020 until today. And he's also worked for Healthcare and Pharma for Council for Healthcare and Pharma, and for Ministry of Health and Family Welfare for the Government of India, for Charité University in Berlin, and also for Noida, India, for Fortis Healthcare. So she also got a number of honors in National Merit Scholarship by GOI, Dhirubhai Ambani Scholarship, Youth Parliament National Award, the AAD Alumnus, and Mentorship Board of Whitehall Hub Physician BC platform. So we, dear gentlemen, ladies and gentlemen, we are very lucky to have her today. So let me just, without any further ado, welcome Ms. Ashana and give the screen to her. Please, Ms. Ashana.
Thank you. I think I see a hand there. Would you want to address that, or should I start with my presentation? And would somebody be sharing the screen for me? I have shared.
Oh, sure. A minute, miss.
Septia, you're mute if you're saying something to me.
Apologies for this long waiting, Miss Ashana. We're waiting on your slides.
And if you can, thank you.
I hope you can see the slides now. Yeah.
Thank you, Satya.
So yeah.
First of all, thanks for having me. And I'm very honored to be a part of this event. And before really moving on to the topic for today, which has been allocated to me, which is Global Action Plan for the Prevention and Control of Non-Communicable Diseases 2013-2030. And I have been asked to specifically speak about role of WHO. I'd like to put the context of where we are, at the moment and why this topic is important. Next slide, please. So WHO's Global Health Estimates 2020 reveal that deaths from NCDs are on the rise. Globally, 7 of the top 10 causes of death in 2019 were non-communicable disease, which is an increase, from the 4 of the top 10 causes in 2000. In low and middle income countries, the premature death rate due to diabetes, for example, has increased across both periods. In February 2021, most countries reported disruptions in services related to mental health services and non-communicable services to the tune between anywhere to can you please advance the slides? Able to move the screen? Anywhere between the tune to 37% to almost 45%. So according to projections, if business as usual continues, there will be approximately 55 million deaths by 2030. For all countries, the cost of inaction far outweighs the cost of taking action on the non-communicable diseases. Satya, can you advance the slides, please? Can you hear me? Continuing business as usual will result in loss of productivity and an escalation of healthcare costs in all countries. The cumulative output loss due to the 4 major non-communicable diseases, together with mental health disorders, is estimated to be around $50 trillion, which is approximately 75% of global GDP according to the 2010 figures. And if we look at the global trends in premature mortality from the NCDs, despite the rapid progress made between 2000 and 2010 in reducing the risk of premature death from any one of the major non-communicable diseases, the momentum of change has dwindled during 2010-2016. at least half of the world's population still does not have full coverage of the essential health services for non-communicable diseases. And over 800 million people spend at least 10% of their household budgets to pay for health. I cannot control the screen. Yeah. So can you go back to the previous slide, please? Satya, can you please go back to the previous slide?
Yes, sure. Like we're trying a little bit.
So coming back to the Global Action Plan, it is a document which has a vision and has the goal. So the vision is a world free of avoidable burden of non-communicable diseases. I think I'd like to switch off my video. Perhaps the bandwidth is getting low in this. So, and the goal is, we can read this. I'll have to really run through the presentation. It's quite long. So next slide, please. Next slide. So the Global Action Program of the WHO, like any other previous slide, the principles on which the Global Action Program plan. The overarching principles that form that the Global Action Plan is built on, like any other work of the WHO or the UN agencies, are listed on the slide, and we can come again at the discussion time for greater discussion. Next slide, please. Next slide. So these are the 6 mutually reinforcing objectives that, previous slide, please stick to the objectives of the Global Action Plan. So these are the 6 mutually reinforcing objectives that we'll be talking in great detail during the presentation of how the different stakeholders come together and drive this Global Action Program. Next slide, please. And I'd like to give you a very quick snapshot of what the 9, you would have heard about this, the 9 voluntary global targets when it comes to non-communicable diseases, and how they have been now readjusted. And so these are the 9 global targets. The first one, and the different color coding is because the first one is to do with mortality, the last 2 are to do with health systems, and the remaining are to do with risk factors, both behavioral and metabolic. Next slide, please. So the key stakeholders, it's very important to understand if we want to really understand how the Global Action Program works. So the key stakeholders can be divided into 3 groups, notably the member states, the WHO Secretariat, and the international partners and private sector. Next slide, please. And in the international partners, I'd like to give you a panoramic view of the UN Task Force on NCD. So all these organizations come together and support the work of prevention of the non-communicable diseases. Next slide, please. So coming to the role of the WHO Secretariat, the political declaration of the high-level meeting of the General Assembly of Prevention and Control of NCDs reaffirms the leadership and coordination role of the WHO in promoting and monitoring global action against non-communicable diseases in relation to the work of other relevant UN system agencies, development banks, and other regional and international organizations. So in consultation with member states, the WHO Secretariat develops a global mechanism to coordinate the activities of the United Nations system and promote engagement, international cooperation, collaboration, and accountability amongst all stakeholders. The mechanism is convened and hosted and led by the WHO, and the report is to the WHO governing bodies. Nonetheless, having said that, it's important to keep in mind that the primary role and responsibility for preventing and controlling non-communicable diseases lie with the governments or the member states. And while efforts and engagement of all sectors of society, international collaboration and cooperation are essential for success. So this is actually the generic view of what the nature of role of WHO is. And we'll see when we talk about all the different objectives of the plan. And when I'll also like to, I'm sure the time is short, but I like to take you through the relevant annexures where different policy menus are laid forth and how the WHO, plays a different role, in driving forth this agenda. Next slide, please. Next slide. Yeah. So this is the objective one, coming to the objective one, which is to do with strengthening the international cooperation and advocacy. So it is very much the WHO is leading and convening all these different stakeholders that we spoke about to basically prioritize this agenda and put it on high table. And also offer technical cooperation by means of special focuses how to link this important agenda with the SDG linkages, the Sustainable Development Goals and the United Nations Development Assistance Framework and poverty alleviation strategies. Provision of policy advice and dialogue. In this, it's important for the organization to keep in mind policy coherence, management of conflict of interests, and other tools and mechanisms as and when required, and dissemination of best practices by means of inter-country collaboration and so forth. Next slide, please. Coming to the objective 2, which is basically the country-led multi-sectoral response. Here again, the WHO is leading and convening, mobilizing the UN system for additional support to the member states, technical cooperation, wherein it technically supports member states in evaluating and implementing evidence-based policy options, driving intersectoral synergies by means of setting up, strengthening national reference centers, WHO collaborating centers, knowledge sharing networks, etc. And here I'd like to make a special mention when the WHO works on the policy guidance and dialogues. It's very important to basically identify and then help the member states address the functional gaps in this domain. And the Secretary General's report has pointed out these functional gaps mainly as advocacy, awareness raising, accountability, resource mobilization and financing, capacity strengthening, technical support, product access, market shaping, and product development and innovation. Here also, knowledge generation by means of producing and disseminating technical tools, decision support tools, information products for cost-effective interventions and measuring their impact, and capacity strengthening by means of one WHO work plan, enhancing the secretarial capacity and capacity assessment surveys. Next slide, please. So objective 3 is to do with the risk factors and social determinants. So basically, the Global Action Plan speaks about reducing modifiable risk factors and underlying social determinants. And here there are 4 of them, which we talk about: tobacco control, promoting healthy diet, physical activity, and reducing the harmful use of alcohol through creation of health promoting environments. Again, we can go into details during the discussion phase, but just a very quick mention of some of the important ones, the Framework Convention of Tobacco Control and implementation of these frameworks and the guidelines, and the data analysis, reporting and dissemination, and how the WHO works across these pillars to drive forth the plan. Next slide, please. So coming to objective 4, which is to do with health systems and universal health coverage. Next slide, please. So Objective 4 talks about strengthening and orienting health systems through people-centered primary healthcare and universal health coverage. So the WHO leads and convenes by positioning this on high agenda and by means of integrating uh, the cost-effective strategies. And we'll see it in a later while how this is one of the accelerator themes in the new implementation roadmap. And and again, all these other areas, policy advice and norms and standards and dissemination of evidence and best practices. Next slide, please. So coming to the fifth objective, which is to do with promoting and supporting national capacity for high quality research and development. Here again, the WHO leads and convenes by means of working with WHO collaborating centers, research organizations, and building up alliances and offering technical cooperation to the member states by means of the WHO prioritized research agenda and policy advice and dialogue by fostering inter-country research. Next slide, please. This is the final objective of the Global Action Plan, which is monitoring the trends and determinants and evaluation progress, very important element, wherein the WHO offers technical cooperation and support to member states to strengthen and work with the national surveillance and monitoring systems, and in regards to the national targets and indicators, setting standards and monitoring global trends, capacity and progress in achieving the voluntary global targets by means of periodic assessments, status reports, reviews, etc. Next slide, please. So, so far, what we have spoken is basically the generic nature. I also wanted to take you through the breadth or through how we have come to where we are. So this slide shows the global milestones in the journey for this element. It starts, right from 2000 to 2020. As you can see, the action plan 2008 to 2013 on global strategy for prevention and control of NCDs, which was then the WHO action plan for prevention control 2013 to 20. And after that, next slide, please. And after that, I'd like to also mention in this regard, key recent resolutions, which help us understanding the evolution of this process. So in 2013, the World Health Assembly decided to endorse the WHO Global Action Plan on NCDs and to adopt the set of 9 voluntary global targets for achievement by 2025. And in 2019, the Assembly again confirmed the objectives of the WHO Global Action Plan, as we've seen as a contribution to the Sustainable Development Goals 3.4, and decided to extend the period of action plan to 2030 now, in order to ensure its alignment with the 2030 Agenda for Sustainable Development. And very recently in 2021, at the World Health Assembly, the request to the DG was made to develop an implementation roadmap 2023-2030 for the Global Action Plan for prevention and control, and that's what we'll be coming to now. Next slide, please. Next slide. Yes. So before I actually go into the implementation roadmap, which gives us very important insights on the way forward, I'd like to mention about this very important publication which came out in November 2020, which is the Midpoint Evaluation of the Implementation of WHO Global Action Plan, which kind of overall the high level messages were that overall that the Global Action Plan has contributed to raising the profiles internationally. Nonetheless, progress in implementing has been slow and incremental, rather than kind of acceleration to which the high level processes associated with the NCD gap aspired for. And it has positively commended work on tobacco and the United Nations Interagency Task Force. More details can be found on the link I've shared in the slide. And hence, it's very clear that more is needed to ensure that non-communicable diseases are managed effectively through primary care so that people with NCDs such as hypertension, diabetes are diagnosed, treated, and have their conditions controlled. There is a need to ensure that vulnerable groups, different age groups, and those in emergency settings as well are included in this provision, as COVID-19 has shown us. Investment in and support for research has been suboptimal. Data are reported regularly by almost all member states, but there is scope for much greater use and analysis of data. Next slide, please. So a very quick view of understanding the timelines. So what has happened in the last year and where we are at and where we are going to go. In June to August 2021, and this is very typical about the WHO processes, and this is how I'm also trying to give you an oversight of how the WHO works for many of its streams. So there were regional technical expert consultations, which was then laid for information sessions for partners in private sector. And therefore, and after that, the WHO Secretariat convened an open discussion forum on a draft implementation roadmap, which is then proposed to be submitted for inclusion in the report to the Executive Board 150 for agenda item 7, which deals with non-communicable diseases. And finally, by May next year, in the World Health Assembly, probably this will be an important agenda item. And the WHO Secretariat, as we'll see later on, is tasked with publishing the implementation roadmap before the end of 2022. And thereafter, the implementation supported by tools would be rolled out and scaled up. Next slide, please. More information on the link which I've shared in the slide. So again, so this report of the WHO Director General to the Executive Board for agenda item 7 will include an annex for each of these sub-items that are listed on the slide. There are 10 sub-items, and one of them is the implementation roadmap. Then there is draft recommendations to strengthen and monitor diabetes, oral health, global strategies, special recommendations for humanitarian emergencies, and progress and implementation of global strategy to accelerate elimination of cervical cancer, and review of progress achieved in prevention control of NCDs and mental health. Intersectoral global action plan on epilepsy and other neurological disorders, draft action plan for effectively implementing global strategy to reduce harmful use of alcohol, and draft recommendation for the prevention management of obesity. Finally, with a work plan for global coordination mechanism. So all this has to be there for the draft provisional agenda that we'll see in January. Next slide, please. So very importantly, now we'd like to summarize what are the actions for the Secretariat to be taken in 2022. So these include, amongst others, and I've really tried to make it as concise as possible. This is all built up on the discussions and that we've already spoken in the presentation. So it's for the Secretariat is tasked to complete the work on development of the global implementation roadmap and publish the roadmap as a technical product before the end of 2022. So in this, if we go into the depth, it's important to develop updates to the Appendix 3, which we've spoken about. Appendix 3 of the Global Action Plan for Non-Communicable Diseases is with the 6 objectives that we've spoken about, the policy menu options, and the various global targets that it deals with, and also the WHO tools that it draws upon. So this needs to be updated, as we've seen, because of the extension of now the strategy to 2030. Propose updates to the new WHO impact framework that will assess the results of the 13th General Program of Work, 2019-2023. Scale up efforts to strengthen health information systems that include NCDs and collect quality, timely, and reliable data, including vital statistics on non-communicable diseases. Develop a dashboard for faster and easier monitoring. Ensure that the operational framework on strengthening primary healthcare includes NCDs. Develop a simulation tool before the end of 2022 using interventions for NCDs which are updated with the latest evidence and aligned to the primary healthcare and universal health coverage frameworks, support the health workforce needs for delivering NCD prevention and management, support countries to foster research and innovations, and scale up strategic communication and partnerships to increase demand for NCDs. Next slide, please. So this, again, I felt it's a bit of going into the depth. I just wanted to give a panoramic view of what these 9 voluntary global targets, which make up the global monitoring framework, which is a part of Annexure 2. So these 9, as you can see, the first one is to do with mortality, and the next 4 to do with the risk factors. And again, the next 3 to do with the next 2 to do with the risk factors, and the last 2 to do with national health systems. And out of these, all of them, but a few, the last 3, they have remained constant, and otherwise every other voluntary global target has been adjusted. Since the timelines have been extended, accordingly, the targets have also been adjusted. So that we can again come back at discussion stage to discuss more about them in the interest of time. Next slide, please. So this is, again, I wanted to capture the sentiments of the work that will follow in this domain, is basically building back the NCD agenda differently but better. And we've seen how the roadmap will highlight the barriers in implementation of NCDs and provide evidence-based and cost-effective options to overcome them. And we've seen how the NCD Global Monitoring Framework, which has been extended to 2030, it will identify pathways for achieving the targets on risk factor control, disease diagnosis and management, surveillance, intersectoral action, financing, and other related areas. So if you go through each of these these themes, you'll get a flavor of what we are talking about. And the WHO in its role will support countries to prioritize interventions based on their NCD epidemiological profile, available resources and other considerations, using a simulation tool, hopefully. And the roadmap will promote a national, voluntary, collaborative, multi-sectoral process, which is supported by partners and relevant stakeholders to advance the NCD agenda and contribute to the Sustainable Development Goal target on NCDs. And this is by way of bringing together the various initiatives and technical packages, in a one-stop shop for easy access, and showcasing country best practices and successes across the NCD prevention control interventions. Next slide, please. So I'd like to conclude finally by quoting from the Lancet, and I just came across this last night when I was planning my talk for today. And it captures really the overarching message that the COVID-19 pandemic not only has revealed and exploited gaps in the current disease detection, alert, and response mechanisms, but also plainly showed that a reset of the global health and health security system as a whole is required. So we hope that in the new year, there will be a reset in many areas of global health and health security system, and most notably, the non-communicable disease agenda. Next slide, please. So a lot of action is required by the EB 150. And next slide, please. In the further slides, and I'll share these slides to be shared with you. I have just, we can come to the discussion if people are interested in the details of, it's not possible to go through each detail in the presentation, but I've laid out the important areas of the Global Action Program, notably the Appendix 2 and Appendix 3. Thank you. With that, I conclude.
Thank you very much. Thank you very much, Miss Ashana. That was a very insightful presentation. Yeah. It was a really surprising to know that WHO has been working very thoroughly in planning for this Ncds phenomena in tackling this issue, and especially on how it keep going on improving from starting only from tobacco policy in 2013, if I'm not mistaken, and then going in including more and more diseases into the draft by salt, sugar intake, and also I also saw epilepsy also included. Now mental health is also considered, which is really surprising and very it's like thought-provoking too, yes, for us, and because in our country, I think the awareness about this is not on that level yet. So it's really interesting to watch your presentation. Thank you very much, Ms. Arshana. Well, we're going to invite our second speaker. So it's Mr. Dr. Irwan Saputra, Escape MKM. So he was a lecturer in Universitas Shah Kuala, Indonesia, and he received his bachelor in nursing from Shah Kuala University in 2003, followed by a Magister in Kesehatan Masyarakat or Public Health from Universitas Indonesia Jakarta in 2008, and also in 2017, he was awarded a doctoral in public health and health financing from the University Kebangsaan Malaysia or UKM and United Nations University International Institute for Global Health Malaysia. So let me just read about his experience in professional experience. So there are so many in the list, so maybe I'm just gonna read the most prominent one. So here he is, and it's from March 2014. He is a consultant and the founder for the Lembaga Hospital Management Consultant or HMC or HMC, with the concentration to improve hospital management, I believe, and also he's also the founder and the master trainer of T1 Solutions Banda Aceh, and the lead researchers for Dewan Perwakilan Rakyat Aceh or DPRA in the section of social wealth. Well, without any further ado, let's just welcome Dr. Irwan. Are you here already?
Yes, thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, Dr. Irwan. Thank you very much for being here. We're very happy to have you. So, the floor, the screen is yours. Please.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Thanks for waiting for this presentation. It's so glad to me to see you all and discuss about the important topics today about the non-communicable disease. I will take the short time to discuss about the topic, especially about the strategy, how to integrate the preventive and promotive intervention to control non-communicable disease. And I start. Okay, right. Integrating promotive and preventive strategy for the intervention for prevention and control of non-communicable disease. This is my introduction for Ncds. We know from Ashana work already clearly about the introduction of Ncds, non-communicable disease, are leading killer today and increase every year. Maybe today in 71% of the total number of deaths each year for non-communicable disease. And then we can see here for risk factor of non-communicable disease, very many of factors that influence the non-communicable disease for high blood pressure, physical activity, obesity, raised cholesterol, decreased vegetable and fruit intake, raised blood glucose, use of alcohol and tobacco use. I think tobacco use is very important thing, especially in our country, in developing countries. I will share to you about the short video about how this video viral in 2010 about the smoking baby. Everyone can watch this video. All right, everybody here, what do you think after you watch this video? I believe everyone here will say, we are so sorry to watch this video. This video is already viral in 2010 about smoking baby. All right, let me move to what we have to do. This topic, the strategy, how to integrate health promotion and disease prevention. Health promotion and disease prevention program can improve health every stage of life. To achieve this, there are several strategies for integrating health promotion and disease prevention perspective into everyday practice. The strategies are, the first one is health communication, how to conduct effectively health communication. Second one is how to develop and deliver the health education to all people. And then the last is how to formulate policy system and environmental change. Let us start with the first point, health communication. Health communication is about verbal and written, and then how to we use multiple theories and models, and then related to social marketing. This is a very important thing to integrate the prevention and promotion in terms of to control non-communicable disease, how to deliver the communication with a good way, and then how to make health communication effectively. First is use of research-based strategies. The second one is understanding of conventional wisdom. This is very important. And the third one is consideration of health literacy. And the last one is develop of material. And then, what is the objective health communication? We know by deliver health communication, we can increase risk perceptions and then reinforce positive behavior and then influence social norms, increase availability of support and needed services, and empower individuals to change or improve their health condition. And then this is strategic media to convey health message by radio, television, newspaper, flyers, brochure, internet, and social media too. And we know today social media is commonly used by young people. And I think we have to learn more how to tobacco advertisement and make young people interest the topic. So to discuss the communication in health, we have to good capacity in social media use to be more interest to share our communication. In Malaysia, an example, they already developed the digital tool that used by community health volunteers to Ncds screening and health education. This is the example of health communication interventions. First, tobacco prevention and cessation program often use health communication to reach a broader audience. And then communication and social marketing intervention related to HIV prevention and treatment are available in rural HIV/AIDS prevention and treatment topics, and promote pre-diabetes screening and diabetes prevention information to communities using multiple media outlets. That we know about what we have to consider for implement health communication. The first one, we have to understand the target population. Who is our target population? We have to investigate. And the second one is we have to tailor message to the communication channel. And the third one, using multiple communication and media strategies. And the last one is the target population has access to the communication channel. Yes, we move to health education. Health education is one way to earn experience on health topics, and particular to health topics, and then provide tools to improve capacity and support behavior change. What is characteristic of health education strategies? First, participation of the target population, and then we have to know what is the assessment of needs, and then increase participation, knowledge and skills, and then implementation of program with integrated, and then presentation of information with audiovisual. And this last one is ensuring public efficiency of program staff. What we have to consider for implementation of health education, first one is enhance the overall goal. We have to know what is the objective of the implementation of health education. And then we have to know what the program must be culturally appropriate and tailored to the target population. And we know in Aceh, many of traditional arts that we can use to deliver our health education. And then the third one is how to formulate policy, system, and environmental change. This is about promote healthy behavior by making healthy choice readily available and easily accessible in the community. What is the policy change that we have to do? Policy change is a tool for achieving health promotion and disease prevention program goals. And then policy decisions are made by organizations, agencies, and stakeholders that we have to make the collaboration for all area, for all sector that can make together the policy, and then how to include legislative advocacy, fiscal measure, taxation like sin tax in Malaysia or market tax, and regulatory oversight. Let's we know to example of policy approach. Yeah. Maybe our government can establish policy for smoke zone in public events, and then establish health food option in vending machine in public place, and then adding a tag on healthy food option like syntax or market, and then requiring to use of safety equipment in a work setting to avoid injury. In Indonesia, we know new paradigm or new perspective of promote a preventive that we call prevent, detect, respond, promote, and protect. From this statement, we can see there are several programs in our public health services. We know like PISPK, Program Indonesia Sehat dengan pendekatan keluarga, or Indonesia Health Program based on family approach, and then SPM, Standard Pelayanan Minimal or Minimum Standard Services. And now we can see new program that called Perkesmas or Perawatan Kesehatan Masyarakat or Community Health Nursing, and then Pandu PTN or Integrated Services Point for Non-Communicable Disease. But the problem today is how to implement this program integrated, and then what resources we have to implement the program, and then how to implement the program. And then the last is how can we use the tool by technology to evaluate and to control, to know the progress, the program integration. And then we move to system change. System change reform refer to fundamental shift in the way we problem ourselves, and then system change affects organizational purpose, function, and connection by addressing organizational culture, belief, relationship, policies, and goals. Next, to implementation strategies involve change the economic, social, and physical surrounding or context that affect health outcomes. Environmental strategies address population health outcomes and are best used in combination with other strategies. That environmental strategies. We can see here how our government increased the norms in the community, and that installing signs that promote use of walking and baking quiets, and the increasing the availability of fresh, healthy food in school, restaurant, and cafeterias. What is the consideration for implementation of policy, system, and environmental change? First, engage partners, stakeholders, and community members in early stage of program development, and then understand the need of the target population to identify appropriate policy, system, and environmental change strategies, and then use health impact assessment to demonstrate the rationale for PSA change, and then assess individual and organizational readiness for change using the stakes of change. And then provide education to the individual and organization who will be involved in implementing of PSA change, and foster partnership and coalition to support broader issues and sustainability, and then ensure enforcement of new policy. And the last one is ensure the regular review of PSA change to evaluate effectiveness and impact on population health outcomes. And I have moved to conclusion of this presentation. Ncds are the main challenge in health system. Respect to management is essential in disease management. And then integrating promotive and preventive requires many strategies from several perspectives and on different levels, including the individual and country level. How to conduct health communication adequately, and then how to run health education effectively, and then how to formulate policy, system, and environmental change. That's all from me. I have a short time to discuss this topic, and I will deliver time to our moderator. Thank you. That's all for me. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Irwan. That was a really interesting presentation. I'm really concerned about the awareness that you talked along the presentation. I mean, like the strategies, the promotion, how to increase the awareness of NCDs, and also, I think it's really interesting to know deeper about that, especially in our context where the awareness is very serious concern, because that is the stage where it's always problematic. I can say so because I can see the policies are there, you know, policies of non-smoking areas, policies about health snacks at schools for children. The policies are already set up, but the monitoring, the evaluation is a bit, I think, challenging for us, for our government. Maybe we'll go deeper about that in the discussion section. Thank you very much, Dr. Irwan, for your presentation. Now we're going to our third speaker, Dr. Martunis, Master of Science, Master of Public Health. So he is the lecturer at the Department of Psychiatry and Mental Health Nursing of Universitas Syah Kuala, Indonesia. Let me just briefly let me just briefly remind the audience before I go introducing the details, the biography of Dr. Martunis. Let me remind the audience that you are now allowed, you are now allowed to write your questions in the chat, yeah, and you are also reminded one more time to keep muted along the presentation, and thank you very much for the presenter who being patient about this, who being understanding about this, and also about your minding the time. Thank you very much to the previous speakers, and to Dr. Martunis, his education. So let me highlight a little bit that he was graduated from Charité Universität Medicine, Berlin, Germany, for Master of Science and also for his PhD. So he started his master in 2011 and finished in 2013, and started his PhD in 2013 and finished in 2016. And he was also rewarded, Master of Public Health for Professional in Maastricht University, the Netherlands. And for his undergraduate study, he received Bachelor of Science in Nursing from Syah Kuala University. So he was, regarding his employment history, he has been working for Shahpal University as a lecturer from 2016 until now. And he also worked for Charité Universitas Medicine Berlin, for American Red Cross Aceh Indonesia as a research coordinator. He also worked for UNICEF Aceh Indonesia as a field researcher, and in WHO. So he took part in WHO Aceh and Yogyakarta, Indonesia, in 2005 until 2006. And his research, he already published numerous publications in health and public health, especially. And his research interest is in epidemiology of NCD, suicidology, and social psychiatry and metabolic syndrome or diabetes. So let me welcome Dr. Martinez. Are you present already? Are you
Yes,
here already,
I'm here.
Doctor?
Yes, can you hear me?
Yes, very clearly. Thank you,
Okay.
Dr. Martinez. I think I'm handing this over to you.
Okay, thank you, Ibu Moderator. Thank you very much for all the committee. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillah, salatu wassalamu ala rasulillah. Thank you for the invitation. I feel honored to be one of speakers for this great international seminar on non-communicable disease. Okay, well, initially I have invitation to talk about mental health, but later it was shift to NCD, the situation of NCD prevention here in Indonesia, especially in Aceh. So I have to change the topic a little bit, but still I hope you can understand my talk. All right, so let me share my slide. Can you see my slide now? Yes, can you see my slide? Pak Said, can you see my slide, Pak? Yes?
Yes, sir, yes.
Yes, okay. Just want to confirm that everything can see my slide. All right. Well, you know, this is the topic the committee wants me to talk about the strategy for the prevention and control. I believe I'm not the really right person to speak about this. It should be someone from the government. But I just give the idea what the document says there, especially from Ministry of Health on the non-communicable disease prevention section. They have published several documents about this. So this is what I want to share with you today. Okay, perhaps I want to show you, I believe this is international conference. We have also speakers from Germany, from Geneva, from India. So I just want to share you the situation in Indonesia. You know, we have around 25 million people. Yeah, 255 million population. It's quite large for us because we are the fourth most populous country in the world. But if you compare from the country where Ashana come from, India, this is only one province. So in our case, we are a country already. In India, this is still a province. I forgot the name of province, but I was there some time ago. So, and then we have the population growth about 1.5% per year. We have 34 provinces, and this is other thing you can see yourself. So, I think I want to focus a little bit about this, about BPS, which is our National Health Insurance System, which was established in 2010, and now it supports a lot, not only communicable, but also non-communicable disease, which is champion for us, you know. All right, so now we see about the current situation of NCD in Indonesia. I mean, current, really, if you go back from 20 years ago, perhaps, you know, the cause of death, this is from 19 to 2015, you know, more than half the deaths was caused by CD, communicable disease. You know, I remember when I was kid, I have neighbors, not only one, but several of them, who suffer from tuberculosis. It was very common disease at that time, but now it's still there, but not as we used before. So as you can see here, 20 years ago, we had a lot of communicable disease, tuberculosis, and so on. But and some NCDs. Injury was 7%. And then in 10 years after that, in year 2000, the communicable disease decreased to 43%, but NCD increased to almost half of it. Okay, in 10 years ago, 10 years after that, the CD decreased, but NCD increased. So more than half the cause of death come from non-communicable disease. And we will see later the list of the causal of the death. And then by 2014, and also now, I think, I have not got the latest data, but like 2/3 of the deaths in Indonesia caused by the non-communicable disease. Okay, so despite the non-communicable disease increase as the cause of the death, but the communicable disease remain high and are compounded by certain emerging and re-emergent disease that appear unexpectedly. So perhaps you remember we now suffering from stunting. We have a lot of stunting. At the same time, we see I have heard there are some elephantiasis cases. Of course, elephantiasis do not kill people directly, but in the long term, it really reduces the productivity and quality of life. So we suffer double burden of the disease. And then we see again from the this perspective, the NCD cause of death in Indonesia. You see that in 1975, it's only 41%. In 2014, it was 71%. Stroke also increased from 8 to 12. Diabetes and the other communicable, other metabolic disease from 5 to 7, from 6 to 7, and then this the prevalence of cancer also increase. This makes sense because I can say makes sense because we have to consider the number of population increase, but also the prevention is not really there. I think we have heard some talk from Mr. Irwan before. Okay. And then let's see the main cause of death. Again, stroke is the most common one, and then followed by coronary heart disease, diabetes, tuberculosis. This is communicable disease, hypertension, and COPD. Okay, and if you see the number, if we say that for stroke we have 21%, which means 1.2 million of population death from stroke. Hypertension also, a quarter of people death from hypertension in Indonesia. Central obesity, this is like emerging cases, Central obesity really has to do with your stomach, the obesity in your stomach. So in Bahasa, we say it buncit, buncit or busi. Some of my friends also say busi, buncit sexy, but it's not really sexy because it really kills you, if you not really pay attention to that. So be careful. So one way, to measure whether your health is good is to take the measurement of your abdomen or your stomach. If you have a certain score larger than average, then you might be considered as having central obesity. Diabetes, it has to do with the sedentary lifestyle that happening in our population right now. Previously, people like to walk on foot, biking, but now everyone has motorbike. At one point, it is good because it makes our transportation faster, cheaper, On the other hand, it also kills us a lot because we do not burn our fat as we used to do. So we really put so much fat in our body, which later might lead to diabetes, hypertension, and so on. So again, diabetes mellitus increased significantly, and then this is also one contributor to mortality and mortality in Aceh in Indonesia. All right, and then what are the risk factors that we have? This is a study from, I think the data from Riskus does. And then here are the most common one is eat less vegetable and fruits, okay? You know that we don't really eat fruits a lot, especially Acehnese. We have this saying that, why should we eat vegetable? Just give it to the animals and then we eat the animals. You know, we eat goat, so just give the vegetable to goats and we eat goat directly. And that's not really, really good, okay? And then, as I said before, insufficient physical activity. We walk much less than before, okay? Much less than before. Meanwhile, a study, not a study, but several studies says that if you want to reduce or to increase your physical activity, reduce your sedentary lifestyle, the first step is simply by, buying a pedometer, even you can use your smartphone where you put the walking calculators. And if you put there, it really motivates you to some extent. I think everyone now has a smartphone, but we don't really use that for our health. We use it for social media and so on. So physical inactivity is really a problem. And then we eat a lot of calories, a lot of sugars, and then a lot of salt also. Salt has to do with hypertension later. And then central obesity, we have discussed about this, and also smoking. Smoking, like you see from the slide from Dr. Iwan, we have even the youngest smokers, baby smokers in the world. I don't know what's his situation right now, but it was viral some time ago. And not like in Europe, where smoking is really banned for the kids. I mean, if you are below 17 or 18, I'm not sure, you can just buy that cigarette so easy. Yeah, you have to show your ID card so you can buy cigarette and also alcohol. Meanwhile, in Indonesia, we have a cigarette seller whose age is below 10. Okay, and apart from selling, he smoked for himself. So and again, the richest man in Indonesia is the cigarette factory owner. Jarum company. Jarum, he owned banking, he owned many business, but his main business is smoking, selling cigarette, and the owner is the richest man in Indonesia. So he said, we have contributed a lot to the country because we give tax, but don't forget that the taxes are actually from us, the buyer, not from them. Okay, so these are the risk factors for NCDs in Indonesia based on the research conducted by Riskus. And then here are some strategies that the government have proposed actually for NCD prevention and control. I think Dr. Iwan already discussed about advocacy, partnership, and leadership, and also for health promotion through life course and risk reduction. Here we target the adolescent and the teenagers because they are the future of the country. They will be the leader in the future. So we have to target them to inform them what the good and best or good and bad behavior. And also we also targeting the enhancing research. That research in NCD is very limited. I don't say very poor because there are some studies, but not as many as is supposed to be because we have large population. We have very diverse culture here, We have different eating behavior between the tribe, between the province. I can say like I said before, here in Aceh, we like to eat meat a lot. Yeah, we like to eat sweet, but we don't like to eat vegetables. In Sunda, for instance, Sundanese, they like to eat the vegetables much more than us. Okay, so those diversity also should be the base for next study, because as I said, when the culture different, the behavior might be different, and from different behavior, the risk for illness are so different. And other things like web-based surveillance systems, strong management information system, data reporting mechanism. Those are the strategy that the government wants us to do. Reality is not really there. I think Dr. Iwan already spoke about this. So yeah, we want to do many things. We have learned from others, but still the implementation is not really there. So this is really challenging. I just want to say briefly about the some strategies based on, just similar to according to the title given by the committee to me. Several regulation and advocacy measures has been developed to create strong political support and implementation of NCD prevention and control to embrace multi-sector involvement in fight of NCD. Okay. Several regulation aspects. For instance, like this one, policy on labeling and daily intake sugar, intake suggestion of sugar, salt and fat in processed food, it's food, and fast food has been there, in form of Ministry Health regulation. I think you can check number 56, 2015. I think before it was 2013, but then revised, and then that's already there. But I believe if we do the study, not so many people really pay attention to that. This is challenging. Yeah, the regulation is there, but the implementation, I think, is not there. But to make it sure, we can do study. Okay, I have not found any study about this. How many people really see this regulation? Or how many factories, how many producers really put this regulation, this labeling, this suggestion in their bottle, on their packages. Okay, so this is also worth study. And then GERMAS, I think GERMAS is also one of them. Yeah, one of the program that the government has proposed. It has not only been launched but already implemented. But how about the efficacy? We don't know yet, because I have not seen any study about this. And then about promoting the prevention of NCD risk factor reduction, the government expects us to increase community participation and detection of NCD risk factor of behavioral modification. Okay, so this part of Fabindu, because for Pospindu, it's supposed to be in each village, but what I've seen, in my surrounding, it's not really there. Some Pospindu are really active, but some Pospindu, some village, we can say it's not. They don't even start it yet. And then increase engagement with social of private sectors, and then using social media for increasing awareness campaigns against NCD, and then enhancing community strategy for NCD prevention through interactive website, mobile application, and multimedia campaign. Unfortunately, we don't see that often, this application or website, even though the government say it is there. When we check, they say it should be interactive, but it's hardly updated. So unfortunately, we plan a lot, but we don't really implement. And then engaging with NGO for the NCD. And then what I've seen, we don't have so many NGOs on health. Yeah, we do have some NGOs, but they like politics, because when they talk about politics, they have some financial backup. I mean, they have good financial backup, because politicians like to keep them, to support them. But when you talk about health, NGO, if there is no donors, then they cannot run, they cannot function. And unfortunately, health is one of them. Okay, and then this is the amount of Pospindu, the number of Pospindu across the countries. In Aceh, we have this number. 449. This is 2014. It might has been increased, but this data from like 5 years ago. It should be has been increased. And then the third is strengthening health service capacity, collaborate with private sector and professional. Yeah, and then at primary care in Puskesmas, NCD is already one of their program. Okay, previously it only covers hypertension and diabetes, but later it also covers the cardiovascular disease, asthma, COPD, stroke, and even cancer. Okay, and many others. You can see in this link the packages of the Puskesmas for NCDs prevention. And here you can see in the website, I just put some of them. Yeah, clinic counseling berhenti merokok. I think we have not seen that at all. Pengendalian konsumsi rokok. I hardly see that. Some of them are already there. Pandu are there. Deteksi dini kanker leher rahim is there. And then kawasan tanpa rokok, I think Pak Irwan already discussed about this. The planning is there, but again, implementation is not there. And also about the gentas, screening thalassemia, aktivitas fisik, so many program has been there. But again, not all of them, not all of them has been implemented. Okay, this is on a number of Puskesmas across the country. This is also from 2016. It should be increased by now. And what's the challenge? What are the challenges? Like I said, the policy are there, the implementation is not there. First, even though we have centralized health system, some province and some district even feel they are independent, So the policies between province or district are different. Some province, some district, when the governor really pay attention for the healthy of the population, then the program will work. On the other hand, when they don't really care about health sector, they focus on building new building, making new road, even though sometimes we don't need it. Then that is focus. Okay, that will be their focus. So they waste money on building the building that we don't need. I don't have to say the example, but we have seen that a lot. And see how many building, big building, million rupiah were waste just for nothing. And then human resource distribution. Also, we that in most of human resource that we have are centralized in urban area. In a rural, let's say in Pulau Aceh, for instance, we don't have health professional as we need. Okay, we still see some patient goes to Banda Aceh with their fishing boat. Okay, so it's a pity to say, but it is happening. Okay? You can imagine with small fishing boat from Pulau Aceh, it's common for them as they are fishermen, but it's not make sense to bring pregnant women in that boat. If something happened in between of the island, we don't really expect that. And then access to proper information versus hacks. There are a lot of people we just like to share whatever they think need to be shared. They don't really check and recheck. And unfortunately, our people really consume this kind of information. They like to do memes or any information from WhatsApp just because they say, okay, this professor say this, and that professor never been exist, or even the name is there, but he or she never do any research. Okay, so this is really challenging to really inform the people or the population with the right information. And then belief on traditional healing is still common. Okay, I don't say this is bad, but when it comes to, let's say, communicable disease or even non-communicable disease, some of information are incorrect. Okay, and then overall low literacy on NCD among general population, and it's also later has to do with their adherence to medication and control. In our latest recent study, we found that among patients with diabetes, the glycemic control of a patient with diabetes in Aceh is very poor. They don't really care about taking regular checkup. They don't really care about the regular medication, and their blood glucose level is very high, and yeah, they don't really care. It's a really pity. It is, but also challenging for us as health professionals. And this is a good research. I think if you want to really see about how Indonesia are coping with epidemic of chronic non-communicable disease, as I said before, that the number is increasing, but the regulation are there, but the implementation is not really there. This is an example from the slide where they inform us about the social determinant of health. And they found that sex and age are the two most common. Education is there. So education is really important. If you have good education, high level education, yeah, you are also more likely to be healthy. Income has to do with health as well, occupation, area of living, marital status, ethnicity, and even religion has its role, but a very, very small extent. Okay, and then this take-home message. What I can say from my talk here is that the burden of NDC in Indonesia is increasing significantly. Okay, and CD are still there. Yeah, at the same time, CD are still there. Communicable disease, and also this is good, but also bad news. Okay, research on NCD in Indonesia has been limited. It's good if you see that as the opportunity to do more research, but it's bad because we have very poor data or information about aspects of NCD in Indonesia. And then I think learning from each other countries is encouraged. And we are happy now we have speakers from different countries. So I hope we can learn each other so that we can improve the quality of public health, especially in non-communicable disease prevention. Thank you.
All right. Thank you very much, Dr. Martinez. That was really interesting. It was really, I love how you eloquently list out all of the sad but true facts about our country regarding this issue, like the irony of the cigarette market, where the cigarette providers actually the richest man in the country, and also you mentioned about the other policy, also the education. Thank you very much, Dr. Martinez. Well, ladies and gentlemen, so this is we have done 3 talks already. So there are already questions in the chat, and thank you, Ms. Ashana, for your initiative to quickly answer these questions. And like you're aware that our time is very tight. Well, but this is that I need to introduce one more speaker. Yeah, this is one of our best speakers as well. So not least, we have Ms. Maya E. Marcus. Apologies, Ms. Maya, if I mispronounce your name. So Ms. Maya E. Marcus, Master of Arts. So she is a candidate of PhD and also lecturer in. Sorry, let me just check the.
University of Göttingen. Okay, let me see.
Yes, University of Göttingen. Göttingen University in Germany. Yeah, and she got Master in Arts. Yeah, Master of Development Economics, and her bachelor degree was Economics in University of Bonn, Germany, and in 2020 she was a research stay at Harvard T.H. Chan School of Public Health, and at the moment she is a PhD candidate in Development of Economics, which is really interesting because she's working on non-communicable diseases in low and middle income countries, which is really relevant with our country. And she is the chair of development and economics of University of Göttingen. And they're also making interesting, distinguished publications that I cannot mention one by one. So just give the screen to Ms. Maya. Please, Ms. Maya.
Thank you so much for the invitation. Let me just share my screen with you. Okay, you can see the screen, right? Okay, perfect. All right, I'm going to talk about cardiovascular disease today in low and middle income countries, and more specifically, the global state of care. So cardiovascular disease, as you all know, is one major non-communicable disease that is already the leading cause of death in high and middle income countries. And it's, I think in 2019, it was in the top 5 or top 6 in low income countries. So it's, and even there, it's increasing in relevance every year. And there's about 18 million lives lost to cardiovascular disease, such as stroke or heart attack every year. So this is, of course, a huge, huge number. This is amongst the greatest disease burdens we actually have to fight right now as a world. And so we have to think about how to prevent these deaths and how to get people into care that are already suffering from these diseases. Prevention is one big aspect here because cardiovascular diseases are actually quite easily preventable in terms of or very cost efficiently preventable, because they can be prevented by even just lifestyle behavior, such as a healthy diet, healthy physical activity levels, smoking and tobacco and alcohol control. And so preventing cardiovascular disease is, of course, the very first step in lowering this disease burden. But even if this is not possible, then the next step would be to get people into the care that they need, so that we find people that have risk factors for cardiovascular disease very early and get them treated so that they never develop a cardiovascular disease and that they never have a cardiovascular event. And so major risk factors for these are, of course, diabetes, hypertension, and high cholesterol or dyslipidemia. And these are the 3 risk factors that I will talk about in a little bit more detail now. And so my research team and I, we set out to have a look at cardiovascular disease risk and care globally, but we found that there are still major research gaps on a global level, that quite little is actually known about how advanced CVD, as I will call it from now on, CVD is already in low and middle income countries, and how many people are getting the care that they need. And so we wanted to remedy these literature gaps by establishing the Global Health and Population Project on Access to Care for Cardiometabolic Diseases, HPAC as we call ourselves. And our goal was to gather a data set that allows for assessing the dynamics of diabetes, hypertension, and dyslipidemia, so that we better understand how prevalent these diseases are already, how good care is for these diseases, and so therefore also what policies do we have to formulate so that we can more easily fight this disease burden. We have done so by gathering a data set that consists mainly of the WHO STEPS surveys, which is a standardized survey that all the WHO member states can implement, that asks a lot on NCD risk surveillance. So there are modules in there on lifestyle behavior. So how much do people drink? How much physical activity do they do? How much salt do they eat? And so on and so forth. They also have access to care indicators, namely whether somebody has ever been diagnosed, for instance, for diabetes or for high blood pressure or high cholesterol, and whether they have gotten treatment for this and so on. And then remarkably also, these data sets have actual biomarker measures. So we have the blood pressure readings of the respondents and the blood glucose measures, so that we can actually have a look and see, okay, how high is their fasting blood glucose? Do we consider these individuals to be diabetic or not, independent of whether the respondent may at that point already know that they have diabetes or not. After the survey, they were of course told then once they have done the measurement, but before they had done the measurement for the survey, they may not have ever been measured their blood pressure or blood glucose, and so they may not be aware of whether they have diabetes or not. So these data sets are implemented in each of the member states, and so what we did was we reached out to all the member states and asked for these data sets, and in a lot of cases now they're also publicly available, in case you're interested in working with them, on the WHO microdata repository. And we have combined all of them into one big data set. And whenever the WHO STEPS service were not available, we complemented them with data sets that were very similar. So a lot of the DHS surveys were similar. In Indonesia, the Indonesia Family and Lifestyle Survey was included. And so now we have this data set that contains over 1.3 million adults from over 70 low and middle income countries from 6 world regions. And these are all nationally representative and population-based surveys, pooled at the individual level. So this allows us really a good insight into what the situation looks like. Here you can see the countries that are included. So as you can see, they're from all over the world, basically in low and middle income countries, and we have a good selection of them. So let me talk about access to care. This is one of our major research foci from the HPAC project. And the way we have analyzed whether individuals that have these risk factors getting access to care is that we use this cascade of care approach. And this works in a way that at first you identify everybody in the data set that has, for instance, hypertension. So by looking at the blood pressure reading and diagnosing basically everybody that has hypertension. And so in our set of countries, we had a prevalence of around 18%. So you can see it's highly prevalent. And you take everybody that has hypertension as basically your basis population, and you set them to 100. And then 100% of who are you looking at. And then from then on, you have a look at, okay, how many out of everybody that has hypertension have ever had their blood pressure measured? And we can already see, okay, we are losing about one fourth of people who have never had a blood pressure reading, even though they have hypertension. And then if we go on, we see that less than half of the individuals that have hypertension have ever been diagnosed. That, of course, also means that once we go to the treatment stage, even fewer respondents have received treatments for hypertension, only around 30. And then finally, less or around 10% of individuals are in control of hypertension, which is, of course, a big issue because if we don't find and diagnose and control hypertension, that will mean that eventually the likelihood is very high that these 90% who are untreated and uncontrolled might develop a cardiovascular disease and will experience either great morbidity or mortality. So it's vital that we work on these different cascade stages. And we see a very similar picture for diabetes and dyslipidemia as well. it's in fact even a little bit worse, because we're already not doing very great in measuring and screening for diabetes and hypertension, and dyslipidemia. And so when we think about policy, there are of course a lot of things that have to be addressed here. So the first stage where we're already losing a lot of people is at this measuring stage, at the screening stage. And this is despite the fact that blood pressure readings are very cheap. You can do it just with a cuff. Diabetes and dyslipidemia are also becoming increasingly cheap, because you can do it with a point of care machines and a simple blood a finger prick test. And so we have to really think about how we can increase the number of tests that we can do, targeted, of course, at people that are at risk for these diseases. But this is really the first important step, that we find the people that have these diseases, because then only we can go on to diagnose them and get them treated and into control. And so at the treatment stage, of course, then the issue is again, okay, do we have the right medication, and do people actually adhere to lifestyle behavior changes, adhere to the medication schedule, and so on and so forth. So each of these stages will, of course, hold their own challenges and have to be worked on, because we see drops across all of them. But it's already very important to see how poorly we are doing as a world in getting the care to the people that suffer from these conditions. Here you can see we have in each region we have very high performers and low performers. So for instance, in Southeast Asia and the Western Pacific, we see that Sri Lanka was doing actually quite well. There's always poor performers. And in general, we see that the Americas are doing relatively better on average in getting the care to the people than the other regions are. So this may also be interesting in terms of policy recommendations. So for instance, in the Americas, Costa Rica is doing quite well. So what is Costa Rica doing that they are managing to get so much better care to people? So these are also countries that we can look to for policy advice, basically. In Indonesia, we have also looked at this. The picture is quite similar to the other countries. So you can see here the measurements stage is missing, because this was not included in the data set, but we have looked it up from a different data source. So about 70% of people aged 45 or higher never had their blood sugar checked, and around 1/3 of people aged 45 or higher never had their blood pressure checked. And that, again, of course, then leaves the next stages, the diagnosis and treatment and control stage at, again, relatively poor levels, as is the case for other low and middle income countries. Despite fantastic programs such as Pospindu, or the possibility to get your blood pressure checked and blood sugar checked for free in Puskesmas. So we really have to think about, okay, how can we go even further and go even further and try even harder to get the care to the people that need them. Yeah, and of course, each of these stages also underlies socioeconomic gradients. As always, the least educated rural areas of the population are more difficult to reach in terms of care needs. And we have to look at each stage individually to figure out solutions. So our first conclusions from this project, and we have many more analyses to run, and there are also many more analyses that we have already run that there's just not enough time for now, is that we do see that the epidemiological transition is already progressing in low and middle income countries. So NCDs and cardiovascular disease are becoming more and more prevalent, and health systems are not fully prepared to deal with this yet. We have to find more solutions. for each individual stage, and also in a way that takes into consideration socioeconomic gradients and socioeconomic patterns. Yeah, so that's it from my side. I thank you so much, and yeah, happy to hear any questions that you may have. Thank you.
Thank you very much, Ms. Maya. That was really interesting, because I see from the first presenter, when Ms. Ashwana presenting a very wide issue, like global issue about NCDs, and then I've become overwhelmed about the fact about how to handle the situation globally, and then it's narrowing down through your presentation that you can see that everything can be handled separately, like focusing on this cardiovascular, focusing on this mental health, for instance, or something else. Just now I become more optimistic about this. Well, thank you very much for all the 4 speakers. Now here is the time for us to be in this discussion section, so the question and answer section. I already invite participants to involve by asking questions, and we already have several questions here in the chat. And we're very lucky that Ms. Ashwana has answered her part, considering the time. And maybe I'm gonna read these question and answers for you all later on, but before to ask for if there is any of you who wants to ask questions directly by raising hand. Please raise your hands if you want to ask questions. All right, ladies and gentlemen, as we've seen in the chat, there are some questions that have been directly addressed by Ms. Ashwana, and perhaps there are still some others who have not been answered yet. So maybe I'd like to go to the questions and see if the speakers can answer it to us. So let me see from the top. We have Usman asking, and Ashana has answered. And is there any question for you, Dr. Martunis?
Yes, I think there is one question for me from Pak Syed. I think he knows the answer, but he just want to test what I say, about the relationship between our eating behavior and prevention. And when you see from, this is culture. So when you see from cultural, anthropological point of view, we have a term we say, don't blame the culture. I mean, the culture is there. The culture live with the community, the people live with it, and it is part of their life. So blaming the culture is not one-way solution to the behavioral change. However, there are theories which says that culture change over time. As you know, that our culture change over time, and people can change the culture because, but blaming is not. It cannot be done. So you cannot blame the culture, but culture can be changed by its people who live within that culture as well. And if we go back to culture of eating behavior, in Aceh, especially now we have Maulid season in Aceh, and this is really like a big gathering eating ceremony here where the people just go and eat whatever they like. It is a culture. We love it. We like it because it has been part of our life. But what we can do is not just to remove that culture, just to say no more Maulid, it's because it's not make sense at all, but to control our eating behavior. Like if you go to the party, in wedding party or Maulid party, the host serve you with several type of foods. The rendang is there, kuah belangong is there, many things. So I cannot name it one by one, but I can eat it because just typical me, perhaps, because I only know how to eat, not to name it. Okay, Arshana, don't laugh because it's me. Okay, Arshana, so the host serve you with many type of food. It doesn't mean that you have to eat it all, but just eat what you want. Okay, just eat what you want and leave it to the others. Okay, so when they serve 6 different type of foods, it doesn't mean you have to eat all 6 of them, but just like pick 1 or 2 according to your need, according to your portion, usual portion, and then that's it. So I think rather than blaming the culture, rather than fighting rather than saying this culture is good or bad, I think just go back to our own behavior. In this case, eating behavior. Eat what you need. Eat what you really need. Not what you want. Okay, but what you need, and that's it. So the culture is there. We like it. But our eating behavior, it won't conflict with the culture that has been exist for centuries. So I think that's what I can say regarding to Maulid. So we have to keep Maulid because I like it. Everyone here like it. I think Mr. Dean, Pak Ismail really love to go to Maulid. But whenever you go, just eat what you need to eat, not to eat all of them. When they serve you with all kuah belangong, then you eat it all. No, just a small portion that you need. I think that's the answer for the question from Pak Said.
I have a very quick point to make. Will the moderator and the organizers allow me? I'm not sure if we are running out of time.
I think it's okay, Ashana, if you want to say something.
Yes, please, Ms. Ashana. Yes, sorry.
So after the heavy-duty technical presentations, I didn't want to seem like a very, very boring person. And just continuing with what Tunis has said already, and Husna also posed to me as a parent, and I'm a parent as well, to a 6-year-old girl now. And speaking about culture in India, I mean, if you're a good mother, you are supposed to take the food and keep running behind the child and feed the child. It's like if you've seen our stories, Krishna and all of that. But if you see it from the behavioral aspect and the scientific aspect of it, for the signal, you should never, and I think Tunis can correct me if I'm wrong, he's from the mental side of things, but for the hunger signals to be there, they say that you should never force a child. The child will ask when he's hungry, and this is something which I learned in Germany. My child was born in Berlin, and there I was doing what I knew and what we've all along been doing, and my nanny said, no, you cannot let the child ask you when the child is hungry. So this is a complete change of culture, and and I see a lot of sense in it, that if the child is hungry, that child will remember to have that hunger signal, which we otherwise, what Tunis was saying, in our age, all of us, including me, we go to a party and we keep eating. We don't know when we are full. Because as children, probably we've been overindulged by our mothers, probably they didn't know. And it was okay and it was cultural. But I think it starts, and just to be adding to what Husna said, it starts with at least knowing, if at least you have a choice of doing it or not doing it. And then comes, okay, some people will still not like to do it because it's culture. And then we would, as scientists, like to think what we can do, because ultimately the aim is to really improve health and not to obviously say anything about culture. All cultures are beautiful. Thank you.
Thank you very much, Ms. Arshana, and Dr. Martinez and Pak Said for the questions. Yes, it's really interesting if we relate this issue to cultures, especially because our problem also raised on the stage of raising awareness. I mean, raising awareness to people how to change their lifestyle. And it's really sad that we have to end this session because we have come to the end of the time limit. So thank you very much for the questions, and for also thank you very much for the presenters for the questions. Yes, I'm sorry. Yeah, let me remind the participants that yes, you can now log into the link for the presentation for the certificates. And let me also thank once again to the chairman of the Yayasan Pembangunan Serami Mekah, to the rector, to the vice rectors, to the dean, and to the organizing committees, to participants, lovely participants, thank you very much, and to very insightful talks from the speakers, to Ms. Arshana, Dr. Martunis, Dr. Irwan, and also Ms. Maya, who's already left earlier. Thank you very much. Maybe I'd like to have a photo session, if you don't mind, with all of you. Please let your video on so we can take pictures. Some pictures with pretty smiles. All right. Okay. Can somebody help me, Munawir? No, I cannot see all the things here. I cannot see all the gallery. All right. A minute, guys. Nggak ngerti misalnya. Like this. Yep. Cool. Okay. Yep. Okay. 3, 2, 1. Smile. Okay, 2 more times. 3, 2, 1. Smile. Cheers. Well, nice. Okay, thank you guys. Thank you very much for your participation. Please wait for our next seminar next year, inshallah. Thank you very much. And yeah, we're going to share the materials later to all the participants in the workshop. So, okay, and if any further questions, just address the committee from the WhatsApp group. Thank you very much once again, and I end this event by saying Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, izin live Ibu Bapak ya. Thank you Alshana, thank you Maya.
Thank you very much.
Thank you, Mr. Martunis.
Yeah.
I can't go to your home.
Martunis, payah aku dagun dulu le tiga gua belangangan.
Yang ke drama pegah-pegah tu. Baik ni tagu gede 40 selawah. Ni nak bijak kamu gede. Jiu sekali.
FKM dah dagun tu.
Ya beres ya.
Dah dagun. Ya, jadi siap kalinya dah dagun Mbak FKM Pak Martunis.
Tak dagun Pak FKM kamu dengan Pak Irwan berpreh benih belangong kena.
Siap.
Pak Iwan nak kerja apa?